in San Francisco. I'm going to be helping facilitate this discussion today with my dear friend Anand Patel, and then hopefully two intrepid discussants from the audience. If anybody would like to volunteer, just putting it out there that you can volunteer here in the chat. And then also if somebody has a case, that would be great if you could bring up a case.
Dan, I think we've had the world's quickest volunteer for a case, which was, it looks like Dhruv has volunteered to present a case today. So we're still looking for two discussants to volunteer with us, ideally at least one identifying as a female or non-binary. So today is International Women's Day, and I'm gonna take like 30 seconds to plug someone that is an absolute giant that I'd like to highlight. So I'm a hem-onc fellow at the University of Chicago, and tomorrow our kind of med campus-wide research day is called the Dr. Janet Rowley Research Day. So Dr. Janet Rowley is someone that if anyone studied for a STEP exam, they may not know her by name, but they definitely know the work that she's done. So she was a giant in the field of cancer genetics. So she identified the Philadelphia chromosome that we identify with CML and Ph positive ALL. She identified the translocation 1517 that's associated with acute promyelocytic leukemia. So Dr. Rowley is someone who is just an absolute giant who I think it was very fitting that our research day falls the day after International Women's Day this year. So I put in a quick chat link to a wonderful article that talks about kind of all the things that she achieved over the course of her career. But this is just one example of all of the incredible women that we all interact with in healthcare as peers, role models, friends, and kind of everything in between. So a very happy International Women's Day.
Thanks so much for that reflection on it. Still waiting on a couple of volunteers to discuss. If you've never done it before, it's a pretty low-key, low-stress activity. You would basically be paired up with either Anand or myself, and we'll kind of like as a team reason through the case together. If you've done it before, then feel free to also join. But let's see if there's anybody out there that's wanting to be a first-time volunteer today. Anand, how's it going out there in Chicago?
Pretty good. We had a 60-degree day today, which I was ecstatic about. So we had record snowfalls for most of February, but March has gotten off to an okay start.
Oh my gosh.
We have definitely gotten a little more outdoor time over the last couple of days than I had. Actually, I'd gotten plenty of outdoor time in February too, but it was mostly shoveling snow. So a little more enjoyable outdoor time. How about you, Dan? How have you been?
I'm good. It's always 60 degrees here in San Francisco, so it's loses a little bit of its appeal. It's not always that special, but it's pretty nice outside. I think I would lose my mind if I had to deal with snow. I wouldn't know what to do with that.
Luckily, Chicago as a city handles snow fairly well. So basically, as long as you can get in and out of your parking spot, once you get on the roads, really that's the biggest challenge of the day. In the meantime, why don't we have Travis and Gurleen introduce themselves briefly if they hadn't gotten a chance to. I'm sure many of you already know both, but for those of you that may be first-time participants or first-time viewers of a VMR, and in the meantime, Dan and I can keep scrolling the chat to look for our two volunteers that are going to step into the lukewarm seat with us.
Gurleen, you go first.
Okay, hi everyone, I'm Gurleen. I'm a fourth year medical student at Albany Medical College in New York, and I'll be going into internal medicine, and I'll be doing the teaching points today.
And I'm Travis Smith. I'm an emergency medicine physician in Jacksonville, CP Solvers team member, and an associate dean for clinical education at LECOM. A proud teacher of Azim. I see him on there. Hey, Azim. And glad to be here.
So Gurleen and Travis both have affiliations with other wonderful podcasts. So Gurleen is a team member of the Cardio Nerds. Travis works with EM Bombs. So tons of great learning that happens outside of the CP Solver sphere when it comes to other means of taking in education via podcast. But yeah, so they're both wonderful podcasts, and I encourage everyone here to check them out if there's any interest. We are still waiting for our 2 volunteers to jump into that lukewarm seat. As Dan said, we'd certainly love for some. Oh, it looks like we have Parth volunteering, and Sonia as well. Given that it's almost 7:40, 10 minutes past our start time, let's go ahead and have Parth and Sonia jump into the lukewarm seat with us. Parth, why don't you introduce yourself first, then we'll have Sonia introduce herself.
Hi, everyone. My name's Parth. I'm a first-year internal medicine resident at Cedars-Sinai, and I went to med school at Albany Med.
Awesome, Parth. We're thrilled to have you. Sonia, do you mind telling us a little bit about yourself?
Sure. I'm Sonia. I am a room fellow at GW here in the nation's capital, where it was also 60 degrees and beautiful today. So I will say the weather was nice, but I haven't done any clinical thinking in a little while. So it'll be nice to come back in with some wonderful clinicians.
We're thrilled to have you. Sonia, why don't the 2 of us team up as a fellows duo? And Dan and Parth, why don't the 2 of you team up? Dan, do you have a preference about whether you want to take Aliquot 1 or 2?
Well, why don't Parth and I take Aliquot 1, and then we'll leave the subspecialty discussion to you guys afterwards. How's that sound?
That sounds perfect. So with that, once Gurleen and Travis have our whiteboard up and are ready to go, you can jump right into your case through.
Sorry, was muted.
Can you see my screen now? Dhruv, talk slow.
Yeah.
You know how I type.
I know. All right. So, and forgive me because I am doing this off of an EMR and not out of a Word document where I can just have everything nicely. Rip to Drew. I don't dictate. Yeah, you're right. I speak too fast and I find that typing's much easier. So, all right. So, chief concern for this patient is hypotension and abdominal pain. I'll give you a little bit more than that because this case is going to be a bit more interesting. So this is a 40-year-old woman who has end-stage renal disease on hemodialysis, diabetes with multiple complications, a history of cardiac arrest twice with anoxic brain injury, and adrenal insufficiency on hydrocortisone, and recurrent systemic infections. She presented to the emergency department hypotensive, and she was initially found to be hypotensive while she was in dialysis, and her pressures remained hypotensive despite her taking midodrine prior to dialysis. And in terms of other symptoms, she does not have, or she said that she's lightheaded, but does not have chest pain, shortness of breath, cough, fevers, chills. And of note, she also has acute on chronic abdominal pain, which started about 2 years prior to presentation. And I'll leave it there for now.
So Drew, is it type 1 diabetes? Do we know?
She's on insulin.
Okay.
Let's just say that much.
Okie doke, okie doke. Well, Parth, this is already a very, very meaty aliquot. There's lots of stuff to sort of discuss here. Do you want to take us through how you're initially starting to think about this case, and then we can kind of go back and forth a little bit?
Yeah, definitely. Definitely agree. There's a lot going on here.
But
So
at this point, you're a seasoned intern. You know, you're looking at that R2 spot next year. So
so the first thing that I'll be focusing on is the hypotension. So the way I approach hypotension or shock is kind of separated into the different types of shock. So wow, the first one being septic shock, cardiogenic, hypovolemic, and obstructive. So with hypovolemic shock, we think about people that are volume depleted, volume down, and she's ESRD on dialysis and is coming after or during a dialysis session. So, you know, we have a situation where she's getting fluid removed, and that can definitely cause hypotension in that case. And then septic shock, you know, we think about infection as the big thing for that. And she does have some localizing symptom here with the abdominal pain, the acute part being new on top of a chronic component with no other details right now. So, you know, the other things we think about with septic shock is if she's got fevers or, you know, what the source of that could be. And so if she's getting dialysis, there's a good chance she has some sort of line in place. So that's a possible source that she could have an infection from. And then cardiogenic shock, we're not given much in terms of cardiac history besides the cardiac arrest, unknown if she has any heart failure at baseline. But, you know, the cardiac arrest can certainly lead to, if she were to have a repeat episode of that, she could get cardiogenic shock from that. And then, yeah, those are kind of my initial thoughts.
in part, you know, you did so many things that I just love, you know, and certainly at this point, prioritizing, like, am I going to think about the hypotension first, or am I going to think about the abdominal pain first? I totally agree with you that for us, you know, triaging with this limited amount of information, we really have to be in like which of those is, you know, the most immediately morbid. And certainly hypotension, which you excellently, you know, sort of extrapolated to shock, has to be front of mind. And you have like a well-worn schema of, you know, is it distributive? Is it hypovolemic? Is it cardiogenic? And then we can add on like obstructive shock there too. You know, did she have a pneumothorax? Did she have, you know, a significant pericardial effusion with tamponade or something? So, you know, that just to like call out, you know, what you've learned during this intern year is you've clearly got, you know, like the big can't miss diagnoses right up front and center. You know, layering onto that, you know, I think that your prioritization within, you know, hypotension and shock to say like, well, we can't really miss an infection is appropriate, even though Drew told us that this patient doesn't have fevers, doesn't have chills, has maybe minimal localizing symptoms. These folks with end-stage renal can manifest kind of like older patients too, that can manifest in different ways. So like they don't necessarily always need to have a fever. And you're totally right that, you know, that the presence of a line potentially is an infectious source, and that they're just qualitatively immunosuppressed. So I think if you look at like all comers with end-stage renal disease, you really have to think like, does this patient have like a raging endovascular infection up front and center? So, you know, with that, you know, you talked a little bit about, you know, the abdominal pain being layered on there. are there any like specific like hypotension plus abdominal pain kind of overlaps that we should be considering at this point? Maybe we can just start like brainstorming a list together. What do you think, Barth?
So causes of acute abdominal pain and hypotension. If she had some sort of ischemic or infarct in the area where you normally see pain out of proportion with ischemia, mesenteric ischemia in the area in the abdomen. Talked about shock, abdominal source of infection. Trying to think what else.
Yeah. I think, right, abdominal source of infections like got to be right up there. Another way you could think about it is, chicken or the egg, right? Did the hypotension beget abdominal pain? Like, did you become hypotensive? You have some tight mesenteric vasculature, and then you start having like ischemic colitis or some sort of mesenteric ischemia? Or did something intra-abdominally then beget the abdominal pain? Did they have like a perforated viscus or something like that? It's a little bit tough to say in this case. We're told by Dhruv that this patient has chronic abdominal pain, and certainly in somebody who has like longstanding diabetes, you can think like, oh, do they have gastroparesis? Do they have recurrent DKA or something like that that's causing their abdominal pain? Or like you mentioned, like a vascular etiology. Do they have chronic mesenteric ischemia or something? So that's certainly one way to approach it. Another way you can think about it is like, is it abdominal or extra abdominal? And not to like bury the lead too much, but one of the Space Learning Series episode that came out last week focused on a case of abdominal pain and hypotension. It actually had an extra abdominal cause for that. So I guess the last thing that I'll say with this abdominal pain and hypotension, after we exclude the emergent sort of intra-abdominal causes, then we can maybe anticipate this case might take us to a weirder sort of less more obscure sort of position. And this intriguing history of this patient having adrenal insufficiency too, that is something that can cause that sort of overlap of abdominal pain and hypotension. So there's a number of case reports where folks with adrenal insufficiency will actually like mimic an acute abdomen, and it's just sort of a manifestation of the adrenal crisis. So you can get hypotension and then this sort of abdominal pain that's otherwise not explained. Maybe Parth, unless you have anything else to say, I think that we've laid out like a pretty decent approach for Anand and Sonia to pick up on. And just to kind of recap at this point, the learning points that I think our audience should get from your discussion is that, prioritize the hypotension because that's very potentially morbid. And then, going to like our tried and true schema for that. And then we can layer on different causes of abdominal pain and sort of get a little bit more in the nitty gritty. But at this point, I think, targeting our interventions and sort of diagnostic energy towards the hypotension is probably going to be more fruitful. What do you think, Barth?
Yeah, I agree. That was very well said. Thank you for summarizing all of that.
You gave me the raw materials, Well, Dhruv, you want to take it away?
Yep. And just letting y'all know, there's going to be 5 aliquots, including the first one. So in terms of the southwest corner, the past medical history is pretty much all that I had said up above in the HPI. Hold on a minute. Let me just make sure that I'm. Yeah.
Dhruv, how long has she been on dialysis for?
It's been about 4 years.
From diabetes?
Yeah, pretty much. And her last A1C that was taken about a month before her admission, or a couple of days before her admission, was 8.5%. So in terms of meds, she's on hydrocortisone, She's on basal and bolus insulin. She's on midodrine. And while she was in the ER, they had started her on broad spectrum antibiotics, thinking that this was a septic source. In terms of family and social history for this patient, give me a minute, because I'm flipping back between two. Let's see. So her mother has diabetes. And hypertension. And her father has hypertension. And in terms of health-related behaviors, she doesn't smoke, doesn't drink, and doesn't use any other substances. And allergies-wise, there are a couple of antibiotics to which she develops a rash. Bactrim, Bactrim, Cipro, and Flagyl and penicillin. And she also had, actually, I think that should be enough. Do you guys want me to go into the physical exam, or do you?
Yeah, go ahead and give us the physical exam and the aliquot as well.
Okay, sure. So on admission, temperature of 36.8 Celsius. Heart rate of 90, but it went up as high as 108. Blood pressures in the 70s to 100s systolic and 40s to 60s diastolic. Rest rate of around 20s to 30s. And satting 99% on room air. Now, when this patient came in, generally she was in mild distress. She was uncomfortable appearing. HENT wise, she had moist mucous membranes, and pupils equal, round, reactive to light, and extraocular movements intact. Cardiovascular wise, normal. The only thing though is that she had a permanent dialysis catheter, which was wrapped, and we were unable to examine it at the time. And she also had a previous arteriovenous fistula. And I believe it was her left upper extremity that had a well-healed scar. The fistula was not in use. There was no palpable thrill over it. Respiratory wise, clear, normal. Abdomen, soft, obese, tender in the left and right upper quadrants, without rebound or guarding. Neuro-wise, she was oriented in all domains, speaking in complete sentences, and without focal deficits. And then in terms of her extremities, at the time, no peripheral edema noted. There were scattered scabs on her bilateral lower and upper extremities.
Scattered what, Drew?
Scabs.
Drew, do we happen to have orthostatic vital signs in the aliquot or no?
Let me see if I can find them. They were, I don't believe they were done.
Okay, no worries. And is that, sorry, and then was that the last part of the exam then, the scattered lesions and scabs?
Oh, she also had a diabetic ulcer on her right foot.
All right. So Sonia, we've got an exam to go on top of all of this history that Dhruv had given in the last aliquot and a half. What are you thinking?
I mean, I think that the main thing that bothers me is that this is somebody who's much sicker than her age. So she has a lot of comorbidities and a lot of different things to layer. But given that we were sort of clued into the fact that we ought to be worried first about hypotension and prioritizing infection, I think that the exam sort of helps us in some of those respects. I wouldn't necessarily discount a quote unquote normal temperature in her case, mostly because she's somebody who has chronic illnesses and may not mount a typical febrile response. But the fact that her heart rate is sort of borderline elevated, it's not clear if it's 90 or 108, it might be irregular. And this definite hypotension sort of confirms to me that we ought to be concerned about the potential causes of that hypotension and thinking about infectious triggers. Possible sources for infection in her case are numerous. So she has this tunneled line, she has this fistula, which isn't in use, but it's sort of unclear why. She's got this diabetic foot ulcer and these scattered lesions or scabs all along her extremities. All of these are potential etiologies, and that's just looking at her. And then when you get to her abdominal exam, I think that the bilateral, the right and left upper quadrant tenderness makes me worried about something intra-abdominal as well. Although those areas being in the upper quadrants also makes me wonder if this is extra-abdominal, as we talked about, maybe a cause of abdominal pain from both diaphragms. That said, the clear pulmonary exam makes me a little bit less worried. Not to say it's impossible, but I think that there's a plethora of possible infectious sources here, and I'd want to make sure that we're looking at blood work and culture data and imaging to try and evaluate for them. The other thing that kind of sticks in my mind in her case is that she has a couple of different endocrine systems which aren't working. So she's got a pancreas that isn't working well, and she's got adrenals that aren't working well. And that kind of makes me wonder, she's 40 years old, so she's not a kid, but she's also not so old that this is, in my mind, necessarily an accumulation of bad luck over the course of ill health over her lifetime. And so I want to also think about potential things that could tie together those two endocrine abnormalities and predispose her to all of these infections that she's having and this abdominal pain that she's having. I think that's most of what I'm thinking, at least broadly. I'd be very curious to see her labs and imaging.
Yeah, I love that. I mean, I think you kind of hit the nail on the head in the sense that this is a patient that we are worried about an infectious source. And as we've received more and more information, it's very clear that there's lots of potential infectious sources. So we have a line, a fistula, this diabetic foot ulcer, and this abdominal pain. I think one thing that's going to be really hard to tease out for this patient, and Dan had mentioned it earlier, is how much of this current presentation is being influenced by her underlying adrenal insufficiency that's now kind of being stressed. So this is someone that has, in my mind, has bought themselves stress dose steroids while we're kind of figuring out what's going on. So at least doubling the hydrocortisone that she's on. The other thing that's hard is, again, abdominal pain can be a manifestation of adrenal insufficiency. So is this abdominal pain kind of something that we should be looking to chase down? In my mind, abdominal pain plus hypotension, my threshold to work that up further and to image is quite low. I don't feel comfortable saying this is all related to adrenal insufficiency and not chase it further. But I think right now we're still struggling to firmly find our pivot point in this case. And if anything, I feel like my net has gotten wider as opposed to narrower as we're getting more information. So hopefully, basic lab work. In my mind, kind of thinking of infectious causes that will make someone get sick fast. I don't tend to think of diabetic foot ulcers as being something that causes someone to get sick fast. So with that in mind, blood cultures and imaging the abdomen are the things that are at the top of my mind. Kind of when that first passes, if that's unrevealing, then we can think about more dedicated imaging of that foot to see if there's an underlying osteomyelitis or something like that that needs to be accounted for. But in terms of kind of prioritizing our workup beyond basic labs, those are some of the thoughts I have is cultures and imaging the abdomen over imaging that leg. The other thing I'll put a plug in for is, whenever we have patients that have fistulas that are no longer working, the etiologies for why that is can be wide spanning, the most common of which is stenosing of that fistula. And here's a plug: if you happen to be at a medical center where you have interventional radiology or interventional nephrology, please get those colleagues involved. Trying to prevent putting in indwelling lines in patients with end-stage renal disease reduces the infectious risk so much for them. Fistula is at significantly lower risk of getting infected compared to any sort of indwelling line, whether it be a tunneled catheter or like a temporary vas cath or something like that. So I'll just make that plug real quick.
All right. I will disappoint you and say that the CT abdomen pelvis that they got, nothing. But let's go into the rest of the lab, shall we? So on admission, sodium of 131. I'll start with the BMP on this one. Potassium of 5.2. Chloride of 93. Bicarb of 27. BUN of 15. A creatinine of 4.71. A glucose of 186. Liver panel was normal calcium, and they did have concern for cardiac features for some reason. So they got troponins, which were negative. They also, because they wanted to rule out pregnancy, got a beta HCG, which was negative. And then her lactate was 2.1, which is high. In terms of her CBC, white count of 19.8. Hemoglobin of 11.6. And platelet count of 211.
Hey, Drew, what was the diff on that?
Diff was 90% neutrophils.
Any EOs?
0.5%. Barely anything. And just to give you a couple of more data points, they also got blood cultures, and a couple of days later, they got a transthoracic echo. Because as you guys astutely made the observation of, tunneled catheters can be a really big source of infection. And by this time, they had also replaced that tunneled catheter with a temporary trialysis catheter. The TTE that they got was technically suboptimal due to her body habitus, but it did not show any overt valvular lesions.
And sorry, Drew, the CT scan, you said it was negative, but was it with contrast?
Let me see. It was.
Okay. Do you think there's a good spot to stop, or do you have more data you want us to do in this aliquot?
Let's stop here. The next aliquot actually, as I put in the chat, there are 2 diagnoses to this case because there's a little bit of a twist.
Did you say the blood cultures were negative, or were you saving those?
I said, no, I haven't said anything about the blood cultures yet. They were drawn.
Well, Parth, with that, series of information and maybe some strategically withheld information, do you want to tackle the data in front of us as we see it?
Yeah, definitely. I will say that the farther we're getting into this case, the more unsure I am. The wider the differential seems to be getting. So just kind of tackling this in order. So starting with the white count of almost 20 predominantly neutrophils. So when we have this high of a white count, we think about infection versus inflammation. There's certainly a large number of causes for a high white count, but I think infection makes sense in this patient. And then the diff, with it being predominantly neutrophils, I don't think there's too much more to glean from that. She's been on chronic steroids, the hydrocortisone. So, I'm not sure if we have a baseline what her white count is. So it's, it would be nice to have a baseline white blood cell count. She's got an anemia, mild anemia. She's also ESRD. Her platelets are normal. Her electrolytes, really just, a lot of these things are very common to see in dialysis patients. The mild hyponatremia, 131. She does have a elevated lactate, which we think about hypoperfusion with that. We look to see if she has a gap of metabolic acidosis, and her gap is 11 right now. We don't have an albumin, which can affect that, but seems to say it's non-gap, and her bicarb is a little bit elevated. And then her other labs, her liver enzymes are normal, and she's got upper abdominal pain. So the liver is in that area. We would think about that, certainly, but this makes a liver pathology less likely. The cultures are negative. The TTE, not showing any valvular lesions, is definitely reassuring, and at least not having any vegetations or from bacteremia previously. And the CT abdomen pelvis being negative, I think we talk about image negative causes of abdominal pain, largely being grouped into like 4 categories of metabolic, med and toxins, functional, and other. With metabolic, DKA, electrolyte abnormalities are kind of key. Doesn't seem to fit, she doesn't seem to be in DKA and calcium. we're not or it's normal. Adrenal insufficiency is definitely one of the, can also be a cause of that, of abdominal pain. So, just kind of big takeaways from this. Looks, kind of consistent with an infection picture, but otherwise not really helpful for localizing.
I think that was fantastic. And your big picture summary at the end, I think, puts, frames us, sort of reframes us all on the same sort of page at this point. And I'm totally with you that, like, okay, we're talking somebody who has like a true hypoperfusing hypotension event with like dramatic leukocytosis. Maybe there's some caveat with, steroids. Does she have like a baseline elevated leukocyte count or something? But, that said, this is looking like sepsis and infection. And then we go on this hunt for, where is the infection coming from? And if we think of like the most common spots, Sonia and Anand kind of like went through, like ticking through, like, oh, is this pulmonary? Probably not. The lungs are not particularly exciting. Is it abdominal? There's this abdominal pain, but she's not like peritoneal. Doesn't sound like there's great signal for skin and soft tissue infection, albeit this question of scabs could be interesting, and maybe we can come back to that in a little bit. And then, lastly, if like your first pass is largely negative, then you have to go like, what's going to hide? And a lot of the time that's endovascular infection. So you're scratching your head until 8 hours later when the blood cultures come back 2 out of 2 positive. And I think last time I was on wards at the county hospital, I had a very similar case to this of, this patient with ESRD, they seem infected, and then we're kind of going down our checklist, and then, get woken up with a page from the micro lab at 2 a.m. saying like 2 out of 2 staph. So I think that your framing of like likely infection, let's find out where it is super appropriate for this. Then one other thing, Parth, that I thought you did really, really nicely at the end there was you said you put a label on this abdominal pain, right? Like you got something even more specific than just abdominal pain writ large, which is CT negative or imaging negative abdominal pain. I'm not sure if this is super familiar. Have folks in the audience seen Portlandia? There's like this one sketch in Portlandia where it's like these 2 people go rogue with a label maker and they just put labels on everything. And so that's kind of how I think about, this problem representation element, where it's like, let's put a label on it. And then you can look up on the CP Solver's website, like a schema for CT negative or imaging negative abdominal pain. And you can consider all those different options. So I think that that's great. So Parth, one question, kind of like thinking ahead, the blood cultures are kind of held as a diagnostic unknown at this point. We do know that the patient got an echo later on, which isn't necessarily, the case. It's not necessarily standard operating procedure with all sort of infection, sepsis, and OS. What do you think, if you could predict the future, like what do you think is going to come back on the blood cultures? And we don't have enough information at this point, but like we can start hypothesizing and thinking down the line.
I feel like this is going to be, the blood cultures are going to be negative. I feel like there's a curveball waiting in here. I feel like it's just going to come back negative.
You think Drew would do us like that? We got one vote for negative. You got 1 vote for negative. I'll get the flip side. I'll say it's positive. And then you're just sort of thinking like, what are common bacteremias in patients with ESRD? And if maybe it's a recency bias I have, but my intuition is that this is probably going to be staph. And then if it is staph bacteremia, you have to ask, where did it come from? And this is what Robbie always told me, is like, where did it come from and where did it go? Because staph it's super sticky, so you have to wonder, is like, did it come from this tunneled line that we haven't been able to look under the bandage for? Did it come from these sort of scabs on the skin? Did it come from this infected foot ulcer? And then you have to ask, where did it go? Did it set up metastatic infection in any specific site? And Dhruv is playing his cards close to his chest, but he did tell us that there's probably 2 diagnoses in this patient. So my bet is that we're going to have like staph bacteremia and then another metastatic site of infection. If hypothesizing, that's not totally off base, what do you think of like the abdominal pain in that light? Like if we did have like staph bacteremia, raging bacteremia with abdominal pain?
Yeah, I think that was really well put. With having the line and having skin flora are kind of the big causes for infection with staph, strep. If she had staph bacteremia with regards to abdominal sources, she could have a mesenteric ischemic picture or some sort of ischemic, some sort of organ that's not getting perfused properly, and that just leads to infection. We kind of, very unlikely to be an abscess at this point with the CT abdomen pelvis being negative. But I think ischemia is the big thing I would think about.
Yeah, no, I think that's great. And, the common things would be an abscess, but you're totally right. The CT should pick that up. And if it's with contrast, we would have picked that up if she had a splenic abscess or a liver abscess. So I think that's awesome. Maybe we're overplaying our hand. There's a whole lot of things that this could be without it necessarily being staph bacteremia, but I can count on, I don't know, 5 different cases that came in kind of similar to this that I've had in the past year or two, where you just have, it's so common, it's such like an incredibly common source of morbidity with folks with tunneled lines, is to have an raging endovascular infection, and then the consequences of that. But you're right, like could she have had a endovascular infection more arising from something within the abdomen? That's certainly possible. And you already in your intern, you're probably seen a ton of GNR bacteremia and whatnot. So why don't we leave it there, recognizing the limits of the amount of data that we have. Like we can't really take it too terribly farther, but we've hypothesized, like if it is an endovascular infection, maybe it's a couple of these ones that we talked about, and then trying to think of other sort of suppurative complications of that.
So, I'm not going to let you off the hook so lightly. So blood cultures did come back, and actually they came back before the TTE, weirdly enough. They were positive for MRSA. But that's the easy diagnosis. That was the reason why they got the TTE. They wanted to see if, because she had MRSA bacteremia and because she had a tunneled cath, whether or not she had endocarditis. So given that the TTE was suboptimal, they were planning on getting a transesophageal echo, a TEE. And in the meantime, they had replaced the temporary trialysis catheter with a new permanent catheter, and the TEE was done the next day. Here's what the TEE showed. A large echo-dense mass with several highly mobile extensions observed in the right atrium, measuring 3 by 1.7 centimeters, in close proximity to the indwelling dialysis catheter, likely adherent to the catheter as well as the right atrial wall and extending to the right atrial wall in SVC opposite the central venous catheter. This likely represents thrombus. However, vegetation cannot be excluded with certainty. And I will leave it there for now. And I will close after this discussion.
And Dhruv, just to confirm, so this is the new catheter that's in right now that demonstrates thrombus on it, correct?
Exactly.
Okay, great. All right, Sonia, I'll let you share your thoughts, and then I'll try to piggyback off them.
Well, surprise, surprise about the curveball. I was waiting for that second shoe to drop. I feel like I understand that imaging helps us to sort of say what's typical versus atypical for a particular finding. If you look at a picture, it looks like something or like something else. In my mind, thinking about clot versus infection, given everything else that was going on, I still worry about infection. The bacteremia, where did it come from? And when did it come from? I think that's what I'm sort of coming back to. I'm trying to figure out the timing of when she started to have symptoms, which preceded switching out the line, and when we have this imaging finding, which happened after the line was switched. And to me, I'm going to have a really hard time distinguishing without getting a piece of that tissue, a piece of that chunk of kind of gross stuff in that atrium, what exactly it is. I think we have to be careful about saying that it's necessarily adherent to the catheter, just because I think that it may look that way, but it may not actually be once we actually see what's going on. And infection, in my mind, is still something that we have to exclude with tissue, particularly because of the potentially weird infections that can happen in these patients. So just because we have a positive culture for MRSA doesn't mean that's the only thing that is growing. Although I think that, no, I'll leave it there. I think that it's possible to have true and unrelated, and I still, given the clinical picture, the leukocytosis, the acute onset of symptoms, would be very concerned about figuring out whether this is infection first and then figuring out what kind of infection from there.
Yeah, I am completely on board with everything you just said, Sonia. I feel very similarly. Just thinking a little bit about, what causes clot in the heart. So using that lens, I think of arrhythmia like AFib that can cause clot in the heart. A low EF, so someone who's having lots of stasis because their EF is 10 or 15%, that can cause clot in the heart. You can have, an indwelling line like we see here. Here we see clot, or I should say something adherent to that catheter within, like a day or two, it sounds like, of that catheter being placed. And typically, when thinking about infected thrombus versus like a bland hypercoagulable sort of thrombus, infected thrombus is something that would kind of, in my mind, align more with that. That, given the fact that this patient has MRSA bacteremia, in my mind, I would not be jumping to anticoagulate this patient. I would want to pull that line. I would want to get access somewhere that's not a central line. And potentially, if we think this patient can go a few days without dialysis, think about a line holiday. I think this patient needs to finish the Staph aureus workup in the sense of getting dedicated imaging of the spine as well, to make sure that there's not like anything going on there. I think that diabetic foot ulcer still needs to get imaged, because even if this patient ultimately has MRSA bacteremia complicated by MRSA endocarditis, we still need to think about why. And that's where I think trying to make sure that we're not kind of anchoring and saying we have everything that we need in place here and we can stop. I think we need to make sure to do our due diligence. The one thing I'll also plug, I think it was in JAMA, I can't remember the study, but there was a very elegant study done at the VA a few years ago that basically showed MRSA bacteremia. One of the things you can do to improve overall survival is to consult infectious disease. So MRSA bacteremia is one of those bugs that's growing, that getting ID on board to make sure that you're kind of doing your due diligence to work up a source of someone's MRSA is well worth doing, and you're giving the patient a mortality benefit from it. So I would make sure that our ID colleagues are in agreement with the workup that we just kind of laid out and discussed. The only other thing I'll very briefly mention is thinking about, with endocarditis, what would be indications for treating with antibiotics alone versus surgery. So one of the things we don't know yet, which is clearance of blood cultures. So we'll see with directed therapy and appropriate therapy if the blood culture is clear. It does seem like, thankfully, one of the thrombuses was very large, if I remembered correctly. Was one like 3 centimeters or something like that? Is that right?
The thrombus that's there is 3 centimeters by 1.7 centimeters.
So I'd have to look it up, but size right now is the only thing that would jump out to me, is getting our surgeon colleagues on board sooner rather than later. It doesn't seem like there's a blown valve from it. It doesn't seem like this patient's clinically in heart failure from endocarditis. The only other thing I'll mention is in patients with endocarditis, up to 80% of them will end up having CNS imaging abnormalities that are consistent or concerning for mycotic aneurysm, and that has surgical implications. So patients with mycotic aneurysms are much more likely to bleed when undergoing open heart surgery of any sort. So getting imaging of the brain would be well worth doing as well. But I think talking to CT surgery is something that I'd be thinking about given the size of this this vegetation / thrombus that's being seen. And I'll stop there.
Mm-hmm. Yeah. So I'll clarify some things a little bit because I love the discussion, but I think a lot of it went to thinking that this was an endocarditis related mass. So interestingly enough, her blood cultures had cleared by the time that this thing was seen. The final diagnosis that we actually saw, and when we took a look at the TEE, it was pretty clear that this thing was most likely a thrombus. And so the final diagnosis for this is actually a catheter-related right atrial thrombus, or a right CRAT. And this can actually occur after injury to the atrial wall upon catheter entry. Although the discussion is apt in saying that this is very fast for a thrombus to basically pop up within a day of this catheter being put in. The complication that we worried about most for this patient was a pulmonary embolus, as a patent foramen ovale or ASD were not found on the TEE. And there were no clear vegetations on it, so endocarditis was far less likely on our differential. This is a patient that I saw while I was on Cards Consult. So in terms of what we actually did for the patient, we anticoagulated them with unfractionated heparin inpatient, and then we bridged them to warfarin. And she's going to get imaging to assess for changes in thrombus size or interval development of PE. And if it doesn't resolve, then surgery might be consulted. But usually you can melt these things away.
Can you talk a little bit about the duration of antibiotics? So MRSA growing still deserves to be treated, even if it was on one set of blood cultures.
Right, and this and I remember correctly, she was still on she was still on vanc during that time. Like she was continuously being treated, even though they had put in a new trialysis line, they had taken it out, and then they had and I think, let me see how long the blood cultures were clear for, because I think they had appeared on the in the admission blood cultures, but they were clear afterwards. Yeah, two days afterward, and after they started broad spectrum antibiotics, they had cleared, and she was just on vanc for that time afterwards.
Awesome. Thank you so much for that case, Dhruv. What a doozy of a case. Dan, I think you were getting ready to ask for reflections from our co-discussants, and then I'm happy to hear your reflections as well.
Yeah, I was just going to add one little thing there, just to frame ourselves around this clinical entity of Staph aureus bacteremia. It's even though it is something that's on our skin, you can never really treat it as a contaminant. I remember like very vividly being a third-year medical student presenting my case, and the intern said, "Oh, sorry, update is like 1 out of 2 staph bacteremia," and I'm like, "Staph's on the skin. I don't really think he's super infected. It's probably a contaminant. Moving on. Problem number 2, constipation." And then like they're like, hold the horses. Like really, there's no the morbidity with staph bacteremia is just so high that you have to treat it as a true infection, and that correlates to like a minimum duration of treatment of 2 weeks in uncomplicated staph bacteremia, which is like their culture's clear immediately. There's no metastatic sites of infection, and they like respond well and are doing very well from that perspective. Even then, even if you couldn't tell that they're infected by looking at them across the room, they get minimum 2 weeks. And then from there, it just starts adding on in like two-week increments, right? So most endocarditis, you're gonna treat for 6 weeks, like osteomyelitis, somewhere 4, 6, 8 weeks of IV antibiotics. So it's almost, I think for this case, you have to assume that that clot's infected. And I imagine this patient's gonna be like a 4 to 6 week sort of person. And this is where I think some of the it's like be a little bit beyond the guidelines of like, is this truly, you know, just uncomplicated staph bacteremia? No. Is it endocarditis with like, you know, some subclinical vegetation? Hard to say, but they also have this infected clot. So it's like, you know, a deep endovascular infection with some element of source control issues. So they're going to have antibiotics for much longer is my guess. But sorry about that, Anand, for you know, that brief aside. Why don't you take it away with the reflections?
Yeah, I mean, I think I first want to thank Drew for a wonderful case. You know, lots of twists and turns, and then just a lot of good discussion around problems that we commonly see in medicine, which is nice. So it's like bread and butter with a twist. So, you know, Parth and Sonia both incredible discussion in terms of wading through these aliquots. They were all very dense. They all had a ton of information to parse through. I'd love to hear both of your reflections on how you now with the retroscope and the hindsight scope, what you think of this case and how we discussed through it.
I'll go first. Yeah, first off, definitely a very great case. Thank you, Drew, so much. Definitely so much to be learned from this case. You know, looking back, you know, it does, a lot of this stuff does make sense now with the MRSA bacteremia, with the skin, you know, the catheter access line. And it was also, I really enjoyed the discussion talking about the thrombus and the heart infection versus not. Like, you know, it's something that I haven't really seen that much of. So it was good to see. And then just kind of talking about bacteremia, some of the teaching points that I've learned are that the conditions that you always want to exchange lines for are, you know, staph, fungal infections, and then also Pseudomonas. Those are the 3 sticky organisms where you definitely need to exchange the line. And then with MRSA bacteremia, the 2 big things that you always want to watch out for are endocarditis, you know, which we were thinking of in this case. And then the other one is osteomyelitis. You know, so if she had some back pain, you know, that'd be also something to think about.
I think the thing I love most about this case is it's yet another thing to add to the schema for image negative abdominal pain. This is somebody who came in with hypotension and abdominal pain and had likely an infected clot in the heart. And so I think, to me, it just reinforces the beautiful variety and spice of life that we get in medicine, where any case can have a twist that we can get to if we reason through it and kind of parse out what's the most relevant and what's the most common. And I think in a VMR setting, we tend to have this concern that, oh, it's going to be a really super rare thing and it's going to be a weird bug, or it's going to be like that one autoimmune thing. But at the end of the day, we had regular bread and butter MRSA bacteremia and a not so bread and butter clot in the heart.
Awesome. And I just wanted to say, you know, that this crew of discussants did such a fantastic job of like identifying, prioritizing, labeling the problems. And, you know, really that was like the fulcrum by which this case progressed. Like if we think back to the beginning, like Sonia was saying, like abdominal pain and hypotension, like, whoa, how did we get to where we are now? And I think it was a lot of, you know, choosing the things that were most morbid, choosing the things that were, you know, pretty much like the most unimpeachable sort of syndromes at the time, and like starting with shock, you know, very, very appropriately. And Parth, like a very seasoned intern, you know, knew exactly what to do with that. And then sort of going on with like this developing sepsis sort of picture, and ultimately finding that this was like Staph aureus bacteremia with a likely infected thrombus. You know, I think it was just like a masterful, like very, very interesting sort of progression of the case. And just wanted to really shout out both Sonia and Parth for their, you know, expert discussion on this.
I'll just say ditto. I know we're a few minutes over, so why don't we turn it over to Gurleen to run us through the excellent teaching points that she's put together over the course of this case.
Yeah, this was a really interesting case. Thanks, Drew, for presenting it. So just looking through the journey through the case, so the first thing we were concerned for was the hypotension. So when we're presented with symptoms of abdominal pain and hypotension, we always have to make sure the patient is stable. And in that case, hypotension would be something to make sure that we're addressing. So when we're thinking about hypotension, thinking about the different categories of shock, and that's cardiogenic, hypovolemic, obstructive, or distributive. So when we're thinking about obstructive causes include like pneumothorax, tamponade, and distributive and septic shock being one of the most common causes of hypotension and shock. And then the other aspect was the abdominal pain. So there's a lot of different schemas for abdominal pain that we could talk about, but the main thing was that there was a Venn diagram between abdominal pain and hypotension. But when we're thinking about abdominal pain, it's also important to remember in silo that it can be related to extra abdominal organs. So thinking about things such as the kidney, the pelvis, the bladder, a heart attack, heart failure, pneumonia, pulmonary embolism, these are things to keep on our radar. But truly in the beginning, we were thinking about hypotension and abdominal pain as a Venn diagram. And when we have these two clinical entities that we're looking at, one way is to choose one diagnosis and list out all the different things that can cause it, and then see which ones would also present with the second. So in this case, one way to filter it out would be to filter out based on which causes of abdominal pain would also have hypotension. So there's a great schema by Jack that he posted on Twitter recently. So the different buckets you can look at, again, are the similar buckets to causing shock. So distributive, hypovolemic, cardiogenic, and obstructive. And then you can layer it down to the ones that could present as abdominal pain. So distributive, thinking about things that can cause infections, specifically intra-abdominal infections that we were initially concerned about, as well as other things like the adrenal insufficiency and pancreatitis would be causes. When we're thinking about hypovolemic shock with abdominal pain, we're thinking about, is it due to hemorrhage or no hemorrhage? So no hemorrhage, things to keep in mind would be DKA that can present with abdominal pain and hypotension. And then with hemorrhage, you would think about bleeding peptic ulcers, a ruptured abdominal aortic aneurysm, and then cardiogenic and obstructive would be similar to things I mentioned, like an MI or tamponade or a pulmonary embolism. So really, after we made that Venn diagram in this journey for this case, the other thing was to see who our patient is. What is the foreground and the background in terms of there's comorbidities that the patient has, like ESRD, which could lead to infection risk, but there's also endocrine abnormalities and adrenal insufficiency. But then there's also risk factors right now that the patient has, the fact that she had a tunneled catheter, which increases the risk for infection, as well as fistula and this diabetic ulcer, trying to localize what could be causing the diagnosis. And then in our journey, we were looking at different clues in the physical exam and the labs to see and further guide where we're thinking about. So the presence of tachycardia, the leukocytosis was concerning for sepsis, and really prioritizing infection as the cause of all of the symptoms. The other thing that kind of helped us pivot and understand what was going on was the fact that the CT abdomen and pelvis didn't show any abnormalities. So now we were thinking if this is something that's outside the abdominal wall, and also thinking about causes of CT negative abdominal pain. So causes of CT negative abdominal pain would include things such as metabolic causes like DKA, calcium, uremia. Those things were normal in the lab, so we were less likely thinking about them. Also toxins, functional, and other causes. The other aspect was, even though our final diagnosis didn't fit in our pre-existing schema of image negative abdominal pain, always important to remember what's going on in this patient. So really, it was the importance of prioritizing infection. And when we're thinking about infection, we have to figure out the time course. In this case, it seemed to be pretty acute onset, as well as where is it coming from? What is the possible source? Could it be the diabetic foot ulcer with underlying osteomyelitis, or the catheter, or the fistula? And then the other aspect was the finding, I think the main pivot point as well was the finding of the left atrial thrombus. So when we're thinking about a clot in the heart, we're thinking, is it just a primary thrombotic process, or is it, in this case, since there was the evidence of MRSA bacteremia, is this an infective thrombus? So causes of thrombus overall in the heart could be due to AFib, or also patients who have a low ejection fraction because they can have stasis of blood flow, or the fact that, like in this patient, there was an indwelling line which would predispose to infection. So that's the overall journey of the case. And yeah, it was a really great discussion. I learned a lot.
Thanks so much, Gurleen. That was great. Thanks, everybody. Appreciate you all joining us on Monday evening.
Have a good day, everyone.
Hi, guys.